Okay.
5, 4, 3.
Welcome to Healthy Frontiers, a show dedicated to the education of our viewers. It's estimated that 80% of the world's population will have back pain at some point in their life. It's affecting millions of people, it's affecting millions of children, and it costs billions of dollars to industry every year for rehabilitation, replacing workers, and for medical costs. I'm sitting here with Dr. Seth Neubart, an orthopedic surgeon who specializes in spinal surgery and has been practicing here in White Plains for over 15 years. So welcome, Dr. Neubart.
Thanks a lot.
Welcome. You know, oftentimes, patients will come to us and we're considering surgery, and they'll ask me, should I go to an orthopedic surgeon or to a neurosurgeon? So why would I tell them to go to you?
Okay. I'm trained as an orthopedic surgeon for orthopedics, and then after that I did a fellowship in spine surgery. So today, if someone goes to a doctor to have spine surgery, the most important thing is that they want to make sure that doctor is fellowship trained in spine. So the people that are doing spine are neurosurgeons and orthopedic surgeons. You can go to either one. It's sort of like if someone was going to have plastic surgery in their nose, they could either go to a plastic surgeon or they could go to an ear, nose, and throat doctor, but they want to go to the one who's just doing noses. So medicine is so specialized now that for spine, there are people just doing spine. So if you're going to have spine surgery, the most important thing is to go to someone who just does spine and is fellowship trained. And that could either be neuro or ortho, doesn't matter.
Understand. Great, thanks. You know, before we even talk about surgery, let's just talk about a spine.
Okay.
I think a lot of people are not aware of what the spine is all about. Let's see, we know that from birth, the nervous system is one of the first systems that's developed, and it needs a lot of protection because it's in charge of forming a lot of other organs and glands. So can you show me the normal spine and show me some of the components of that spine?
Okay, good. I brought a spine model. This is my good friend from work.
This one didn't make it?
This one made it in plastic. And maybe what I'll do is I'll just go through, I think today maybe we'll just talk about the lumbar spine, because that's the most common complaint that people have.
Right, that's where the 80% number comes from, is lower back pain more than.
So, I mean, there's so much to talk about with spine, but just so people know, the spine is usually divided up into 3 parts. There's the cervical, thoracic, and lumbar. And lumbar is what we call the low back. And in this model, just to orient people, this is the small of the back. The buttock could be here, legs are coming down here, and the belly button is actually way up here. So you have a big belly, and the spine bones are very close to the skin in the back. So a lot of people have this type of back pain. Some people have pain going into the legs on either side called sciatica. But the spine is made up itself of bones and discs. So there's bone, 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 disc, disc, disc. The disc is a cushion between the bones.
So it's softer than the bone, is that right?
It is softer. It's almost like the consistency of a rubber tire in the car. So what this does is allows the spine to move, to bend forward and back. And if you're jumping up and down, it keeps it strong.
So it's like a shock absorber in a car almost.
It does. It makes it flexible. But the reason you want it to be able to move yet stay stable is because inside, underneath this shell, it's almost like a lobster shell, inside there are the yellow. The yellow are the nerves. And the nerves come from the brain down the spinal cord. The spinal cord ends at about over here. And the spinal cord is something that's very, very fragile and has to be protected. And it's almost like a fiber optic cable. So that is something we're very, very, very careful with. From this point down, we have a lot of nerves called nerve roots. And it's a little bit safer to work down here, and people are always worried about getting paralyzed from surgery. And this is a very safe area to work because we're dealing not with the spinal cord, but just with the nerve roots. And the nerves come off at every level. So if you look at this model, the nerves they're cut here in this model, but you can see these yellow nerves, each one coming off. So this would be the patient's right side, this is the patient's left side, and each one goes to a different area. So this goes to the hip, to the thigh, to the knee, to the big toe, little toe,
and you mean all the muscles are controlled from this, and all the organs in our lower body, everything's controlled.
Exactly. So this nerve goes down into the leg, and this controls things like pain, temperature, sensation,
Right.
Wiggling
your toes.
Right. So some people, if you pinch this nerve, the
Yep.
person may feel pain, another person may feel numbness, another person may feel tingling, another person may feel like there's a liquid on their leg.
Okay.
So anytime someone comes in with a leg problem,
Yeah.
I always think of the nerve above.
Right.
And things that can affect it, well, which we'll talk about in a little bit, would be
Yes.
something that pinches the nerve.
Okay.
What else do I want to show you? In the back, there are a lot of joints, and these are
Yes.
called facet joints, and these allow the spine to move in certain directions, but also prevent it from moving in directions that are dangerous. So
Okay.
the whole structure allows movement, yet it keeps things stable so that the nerves don't get pinched and injured as the person moves through.
And isn't it true, Doc, that this bottom part of our spine doesn't have a lot of protection? That's why they have a term called cauda equina,
Well,
which means like a horse's tail.
yeah.
So is that the reason that there's a lot of back pain, would you say?
Well, I think that we see a lot of back pain because people are not behaving the way we're built to behave. You know, I think we're
Okay.
doing things. You know, people come in, they're amazed they have back pain, yet they're out, you know, working, you know, with shovels the wrong way, or they're sitting in a chair all day. They're obese. They're not taking care of themselves. But then again, we see people, as you know from your practice,
Yes.
are just normal, healthy, you know, thin people, and they have back pain too.
Yes.
So a lot of back pain is a mystery, and I think for us, the job first is to find out what is causing the pain, and then we
Right.
can figure out
You
how
gotta
to fix
you
that.
have to get the diagnosis of what
Yeah,
is going on.
exactly.
Why is the
Yeah.
patient having the pain?
Yeah.
Okay. I mean, do these vertebrae at times misalign? And can they press on these little pads? Is
Right.
that one of the things
Yeah.
that can happen?
Right. So the thing is that people, for us, the big thing is as soon as sometimes people come in, I think they're going to need spine surgery, and it's like first thing I do is like slow down. First we have to find out what's wrong,
Right.
because spine surgery typically will work really well if we know what we're fixing.
Yes.
And a lot of the times you'll see people who have not gotten better from surgery, and it's because what we fixed was not the problem. And sometimes we have to fix them anyway and even take a chance. And that's why, you know, I'm not afraid to say it. There are people out there who have had a spine fusion that have not gotten better.
Right.
But ahead of time, we've told them, you know, we don't know where your pain's coming from. We're going to try to fix you.
Right.
If you don't get better, you don't get better. But when we know what's going on, the success rate is very, very, very high, even 98%. Good to excellent results.
Oh, that's great.
So the important thing is just to let people know what we're dealing with, and in order to
Right.
do that, we have to get a diagnosis. So
Okay.
the most common things that cause pain for people
Yes.
now are things that pinch the nerve, and
Yes.
the most common thing would be a herniated disc. And
Right.
and here's an illustration of a herniated disc, and you can see this blob, that's the central portion of the disc, has come out and is putting pressure on this nerve. So this patient will come in with pain down the right leg,
Yes.
down all the way here, associated with maybe some numbness, tingling, even some weakness.
And does it matter? I mean, the amount of pressure, does that equal how much pain this person will have? And dictate
Sometimes,
that
you know,
they might
it's
need surgery?
sort of funny. Sometimes we'll see people with a big herniated disc, and
Yes.
they come in, they say, you know, on the MRI scan it's gigantic, and they
Yes.
absolutely need surgery, and they have very little symptoms at all. And
Right.
I say go home. You know, they don't.
Yes.
Other times I'll have people with a little herniated disc screaming in pain, and people say you don't need surgery, but actually they do. It's
Yeah.
almost like having a pebble in your shoe. I always tell people, it's
Yes.
like you can have a big pebble between
Right.
your big and second toe, walk a mile.
Right.
You can have a little tiny pebble underneath the ball of the foot, you can't take 3 steps. So
Okay.
it's a mechanical phenomenon, and it's how it affects us. If this disc herniates over here,
Right?
they would be sitting home watching TV.
Okay. They won't even have any pain?
No.
Okay.
I mean, they may have a little pain when it happens,
Yeah.
but it's not really something. If it herniates backwards and jams the nerve,
Yes.
and it's tight here, maybe from some arthritis, and the nerve is really pinched,
Yes.
they're going to be screaming in pain, and they'll be begging you to get
Okay,
fixed.
and now just so I'm clear on this, the disc itself doesn't have any nerve fibers, as I understand.
Well,
There are very few.
Yeah.
So it has to do something to another part.
Right. So
being
there's
the nerve.
Well, here's the thing. Everything in the back does have nerve fibers. And this is where it
Okay.
gets a little complicated in that sometimes people have pain, but it could be coming from the disc. We call that discogenic pain.
Yes.
Sometimes it could be coming from these joints, arthritic
Right.
pain there, and that's called facet pain. So just listening to people talk about their pain,
Yes.
we can usually get an idea of what kind of pain this is.
Whether it's the facet
Right.
or it's a
So-
disc.
Right. So for instance, if
Okay.
you have a guy who's a laborer,
Yes.
and he's got a low back pain every time he's digging and moving,
Right.
but no leg pain,
Yes.
that's probably not going to be a herniated disc as much
Yes.
as something with the disc being degenerative and worn out.
Okay.
If you have someone who has pain, maybe just with extension when they lean back and they hear a little clicking in their
Yes.
back,
Yes.
that may be something called a spondylolysis where the bone is actually cracked.
Okay.
So they may have that type of pain. So most of the time, I will tell you, even without an MRI, I can just listen to the patients talk, as most spine surgeons can, and it's almost fun to sort of guess what the problem is, to get the MRI. The MRI is usually gotten just to confirm it.
So the consultation and the examination is so important.
It is, really, yeah.
Okay.
But of course, since we've had MRIs, it's really simple, because the MRIs take a clear picture. I think the best thing about the MRIs is that they're so clear that the patients can actually see what the problem is. So they like to see it. And once you see the herniated disc and you're having pain, it's just clear as can be.
And that's it. We know they need the surgery.
Yeah, if so. But I will tell you, even with a herniated disc, 90% of people get better without surgery.
90% get better without. So, so if they go to alternative care, like a chiropractor,
I mean, if people come in, I usually give them at least 6 weeks. I like them to wait 6 weeks unless they're in unbelievable pain or they develop weakness or significant.
So they have a 6-week window usually.
Yeah, 50% of people will get better in 3 weeks, 90% in 6 weeks. So I will manage the people. That's why I'm sending them to you. And you and I have been working for 15 years probably together.
Yes, correct.
So what are they going to try? They're going to try physical therapy, chiropractic, acupuncture, massage. I don't care. I kick them out. And most of the people get better on their own. If they're still having pain, then they come back. And
those are the ones that we need.
And by that time, they're begging for it. And they get better immediately. It's really wonderful with the herniated disc. But if you have a problem with the disc itself, then it's going to be a little more complicated, because it's not as simple as the herniated disc, just taking that fragment out. And that goes into things like arthritis.
But no matter what I find is a lot of patients are so fearful of surgery. I mean, just the word surgery, the anesthesia, the going in and thinking of having screws in their back. So what are they most afraid? I mean, how would we allay their fears?
Yeah, I think the spine surgery fear is a big problem for patients, because on the one hand, it's justified, but on the other hand, it's a little bit exaggerated. But I see people come in and they're petrified sitting on the chair. They don't want to be there. They don't want to have anything to do with it. But the pain is so bad they have to do something. So the first thing I always do is I always explain the fear. In other words, is this something that's justifiable? People are really worried about getting paralyzed, quite honestly. So how many people are getting paralyzed? They have to know that. It's almost like flying on an airplane. If you fly on an airplane and you ask the pilot, can we crash? He'll have to say yes, but really that's not the question. The question is like, what's the chance of us crashing? Oh, 1 out of 50 million. Well, then you get in the plane and you go. So with spine surgery, you really want to know, if you're contemplating surgery, what's the chance of dying? What's the chance of being paralyzed? What's the chance of having a bad outcome, infection, bleeding, injury to other part of your body? And then when you look at those statistics, then you can make a good decision. So if people understand what we're doing with the surgery, then they sort of understand the complications they can get into, and they're all reasonable. And I think people will then agree to sort of consider this and go forward. But initially, a lot of people are in pain for months, and they just have it blocked out of their mind because they heard someone at a cocktail party had a terrible result, and they don't want to go. But they really need to speak to that person and see what operation they had. Because
type of operation.
Exactly.
What was the problem to begin with? How bad?
Yeah, microdiscectomy surgery does great. And patients, over 95% are doing really, really good to excellent.
That high, 95%, huh?
Yeah, and it's the 5% that, that aren't good to excellent are still good. I've never had anyone get paralyzed or die from that type of surgery. It's not, and I've been doing this for all these years, it's not, I would consider a dangerous thing, nor it should be done, it shouldn't be done just for no reason. I mean, you have to have a reason to do it. If you're going to have a spine fusion, then you really have to think and you have to go over those complications, because they're different than a microsurgery.
Okay, so it's going to determine how much time they're going to get back to work and all those other things.
And the thing is that patients have to realize is that spine surgery has changed a lot in the years. So a lot of the people out there who are limping with a cane had surgery 20 years ago. And now we have all these new techniques. And more important than the new techniques in doing the surgery is almost the new techniques with diagnosing the problem. So, we probably wouldn't even have operated on that person now or done that same operation. So the results we're getting are really good. But people are still being influenced by the history of spine surgery. One thing is you could see the spine is just so complicated, and it's just so many things that before MRI scans we'd have no idea. We'd have to basically open them up from here to here to see what's going on. Now we just go in exactly, because the MRI points to where the problem is. We go exactly to where the problem is and we get out of there before causing damage. It's almost like if you're like a police SWAT team and you have to get a sniper, and you don't know where they are. You got to blow into every apartment, and you create all this mayhem. Maybe you'll get the sniper, as opposed to having information that the sniper's in apartment 6A. You go in, do the job, and get out. So that's what we do now with microsurgeries, because the MRI tells us where to go. We go in, do what we have to do, and we get out.
And as quick as you can get out,
and we don't do any damage. Yeah, we don't take any bone away. We don't do any destruction. We don't even take the whole disc out. We just take this blob of stuff that's there.
Right.
So the patients wake
that
up.
nerve, maybe that sciatic nerve. So
we free it up.
Yep.
And the first thing we do is identify the nerve, free it up,
Right.
take the disc fragment out, and they're done. That's it. They're fixed. And then we just sew them up, and it's less than an hour, and they go home the same day or the next day. But they wake up, and the pain and the leg is feeling good.
The leg is feeling good.
Yeah.
Okay. So one of the key criteria then for even any spinal surgery, you would think, is that they have to have leg pain, numbness.
They have
most
to have
times.
that for disc surgery, right?
Yeah. If someone's just having like chronic back pain, even though it might be disabling to a degree, they may not need surgery. There has to be something in there, because again, a question will come to me. That, well, my back is killing me, doc, but I really don't have leg pain. I mean, should I have surgery? I mean, something going to relieve this.
Yeah. So when they have that type of problem, when you have someone with low back pain, chronic low back pain, and also let me just tell you what chronic low back pain. A lot of people come in, they have back pain for 2 weeks. Come out and go home. Okay, that's not back pain. Back pain. 6 months, because back pain takes a long time to get better, as you know.
Yes.
So it's not like hitting your knee against the table, 2 days later you're all better. With back pain, I think people, if they're not better in 2 days, they get nervous. And then 2 weeks go by and they get really nervous. 3 weeks, they think they have cancer, they're going to die. But they're not a surgical candidate. Go home. Stay away from me.
Maybe change some of their home activity, some of their...
Go to you.
Go to a chiropractor, right? Maybe that would be a great idea.
I'm the last person people should see.
Okay.
But if you got someone, if you call me up and say, look, I've been working with this guy for 6 months. He's dying in pain. He's just not getting better. And when people are in pain, it's terrible. They get depressed. They're screaming at their kids. They're not nice to their spouse. They're not working, so they don't feel good about themselves. They're gaining weight. They're starting to drink. They're taking pain pills. They're constipated from the pain pills. They're not sleeping. They're horrible. So I have people come in. A wife will come in with their husband, just drop them off. It's like fix them.
Your job.
It's done.
Bring them home as a new guy. The guy married.
These people are horrible. And you know what? I feel bad for them, because it is being in pain. We could all be in pain for a day, 2 days, a week. 6 weeks in pain, people go nuts. And that's when you really have to feel bad for these people. And a lot of people say, well, you're doing these spine fusions and people aren't getting better. And you know what? They have to speak to these people who are living in pain, because it is a horror. It's a hell living in like that. So if we can get, even with some spine fusions, believe it or not, the success is with certain cases, it's as low as 50% getting them better. But you know what? If you're in pain 100% of the time, 50% looks pretty good.
Looks pretty good at that
time.
Sure
does. I have people that have had surgery, that have not gotten better. And if you say to them, "Are you glad you had surgery?" They'll say, "Yeah, I had to give it a shot." But for the 50% that do get better with that type of operation, they're thankful, and they're
back to their life, and they're back to being the way they were.
Right. So if you have someone with pain, it's going on month after month. And they don't have the leg pain. And there's no herniated disc. You got to really look to see where's that pain coming from, and it could be coming from disc degeneration. Arthritis of the facet joints. And sometimes we don't find anything, and we'll just tell those people, we don't know, you're on your own. Best of luck to you. But if we can find something where we think the pain is coming from, we'll offer them the operation, and that's where the spine fusion comes in.
So with that, why don't we talk about a spine fusion? Exactly what do you do in a spinal fusion? So
the thing is that this is where technology has changed quite a bit also. And what we've realized is that sometimes when we do surgery in the past, let's say 10, 20, 30 years ago, they were doing more destruction and creating more mayhem. So you'd fix the problem, but you'd end up with all this trauma from the surgery. So over the years, all the surgeries have been designed now to become simpler, less traumatic, and safer. And that usually means smaller incisions. And the end result is that we have less pain from the surgery. So patients are up quicker, and
back to work sooner.
Back to work, out of the hospital,
exercise
walking
if they
around.
want sooner.
So even the patients that may not get better from surgery, they're no worse, and they're up walking around. And that's the goal. The people that get better, it's wonderful. So if you have a problem, let's say you have a problem with a disc. Let's say this one here. This is the lowest disc, and frequently is the one that's involved. These two, L4, L5, and L5S1.
Why do most people have pain back in the lower back? That area.
Yeah,
it's right across the waistline,
that's a good question. But you see the spine enters the pelvis, and this is all a stable unit.
Yes.
This is where the mobility is, and I think that this is where it's getting worn out.
So that's where most of the movement is.
So you have the people, doing a lot of lifting and bending, and they just wear it out. Maybe they have an accident, a car accident, or injury on the job, and they have this pain. The pain's radiating through the whole of the back, and again, totally disabling. Any type of lifting, bending movement, it just hurts, and they don't want to do that.
All right.
So we can do some testing, and if we isolate the pain down to one of these levels, then we can say, you know what, this is where the action is, this is where the problem is. And maybe a way to think about it is, if you think of the spine not like this, but more like this, think of it more like a train. With these are the cars of the train, and the train's going down the track. These are the couplings between each train car.
Okay.
If you have a coupling in a train that's shot, let's say someone took a handful of sand and threw it in the coupling in Chicago. By the time you're getting towards New York, that whole train is going 5 miles per hour. That thing is screeching. Nothing's working on the whole thing. It's almost like a patient in pain. When they have one disc that's out, their whole body's not functioning. They can't lift or bend or walk. So the train comes into the station. The first thing you have to do is you got to figure out which one it is. So you touch each coupling on the train cars. This one's red hot. That's where the action is. So just like with a train, what would you do? You could either take the coupling out and replace it, or what you could do is you could take the two train cars and you could just weld them together, make one long car. Okay, you make one long car, train leaves the station 100 miles an hour. All of a sudden the whole thing is working well. Because you've taken out that one one joint that's really slowing the whole machine down. So we do the same thing. If we have a patient that has a disc that's shot, what we can do is we can actually fuse the two bones together. And what we do is we take away that motion. And then the first thing people say is, well, my back's going to be stiff, I'm not going to have any motion. And I always tell them, your motion stinks now. You got no motion anyway, your whole body's not moving. So we take away the motion. What happens is you take away that bad motion, and all of a sudden everything else starts moving great. So their overall motion is wonderful, and the pain's gone, just like that train going 100 miles an hour. Now, you can't do that with 20 cars in the train, but you can do that every 6 cars or so. You can have a long car, no problem at all. So if we have a disc that is a problem, that's exactly what we want to do. We want to immobilize that bad motion segment. We want to take that coupling and bond it so it doesn't move, take the motion away, because the motion hurts. A lot of people in pain, as you know, they'll come in and they'll be sitting like this, like one position. They try not to move. And actually, they'll talk to you like this. Then they get up to move, and they got pain. So it's the movement, the lifting, bending, all that stuff that kills them. If you hold everything still, floating in a pool, a lot of them are very comfortable. So what we try to do is find the abnormal motion segment, find the disc that's hurting, and then we have to fuse it.
So when you fuse that disc, so now we immobilize the area, and you use certain screws, and I think people have a fear of screws. So that's the next thing people say. The first thing people say is, I'm not having surgery, I'm going to get paralyzed. I say, you're not going to get paralyzed. The next thing I say is, well, you need to explain how you need a fusion. That part, especially mechanical people, will get that part. But no screws. And I said, fine, don't get screws, but you're going to fall apart. And then they're interested. So I don't like to use screws, but you got to use screws. It's the best way of doing it. And if I have my back done, I'd want screws because I want to get fixed properly. You want to talk.
So I'll explain it to you, and then you'll see why screws are wonderful.
So so if I can interrupt you just for a moment, you're going to put the screws in here, but there's a lot of nerve tissue you told me before. So now, if all these nerves have a chance of possibly being irritated by these screws, what are we doing nowadays to make that more safe?
I'll tell you about that. Let me run through the fusion real quick, because it's one of my favorite operations. So one of them. So so we're going to fuse L5S1, but let me show you in this other model. So what we're going to do is we have, this is a breakdown model of this same thing here, but it's going to be smaller.
Small model.
So if we want to fuse this bone to this bone, the way to think about it is almost like it's carpentry, like wood. I'm basically just a fancy carpenter. I'm not even that fancy.
That's right. Oh, you do a good job, as I hear.
So if you have two pieces of wood and you want to bond them together, what you got to do is you got to get some glue in there. But if there's a space between the two pieces of wood, you can't just pour glue in there, it'll pour out. So what you do is you get another piece of wood from the floor, a little piece of a shim, whatever. You put some glue on either side of that. You put that there, and you take a mallet and you tap that wedge of wood with the glue on it in the space. And that fills the bond there. That fills the space and makes a bond.
So you still have a space so that nerve can come out like this.
The nerves are all going to be free. Don't worry about the nerves, But just for the bone to bone, I want something in there. And that's what you do with wood. Now, we're working with bone. We don't use pieces of wood. So what we use is a spacer. And the spacer we're using now, it used to be metal, but now it's made of plastic called PEEK. It's a really strong.
What is it called?
PEEK, P-E-E-K.
Okay.
And it's a very strong plastic. And inside that is a glue, a synthetic glue called BMP. We used to take bone from the pelvis of the patient, which is very painful and a complication. Yeah, we don't do that anymore.
Okay. All right.
We take little bone graft substitute from the bottle.
Yes.
It's made in a factory. It's called BMP.
Okay.
And we put that in the cage. And then this we actually just insert into the disc space.
As a spacer.
As a spacer.
Keep that space.
Yeah.
Okay.
So it just goes in there, and the glue then can bond between the two pieces. Now, just like when you have the wood between the two pieces of wood, after you put that in there, you can't just leave it alone, it'll fall apart. You got to put a clamp on it or a vise, or you got to fire some screws across it to hold that wood strong until the glue sets. Right, the screws hold it. Well, we do the same thing. If you just put this in there without anything else to support it, it's still going to be a little loose and it may not bond. So what do? We take a screw.
Yes.
Because it's metal and it's strong.
Okay.
Okay. We take one screw, we put it into the bone.
Yep.
We take another screw, put it into the bone.
All right.
And we connect it with a rod and then lock it into place with 2 locking nuts.
So
and you get like it's almost like a U-bolt.
Okay.
And it's rigid. And we do it on both sides. And what you end up with is this nice, strong, stable construct down here. So there's no motion. And if there's no motion, it's almost like a cast internally. The patient's immobilized. So they get out of bed the next day from surgery and everything's strong and stable. So do the screws look horrible? Yes, they scare people, but actually they're all inside here.
Okay.
They're very well contained. There's only this top part is sticking out when you're looking at it, just a tiny little bit. They're actually lower than the natural bones that you have in your back anyway, so you can't feel it.
You don't feel them.
A lot of people come and say, oh, I feel the screw, and they're actually
Can they
feeling.
dislodge? I mean,
we have not.
Have you ever had any of that in
We've
your
had
experience?
over 16 years. We've had a couple of screws dislodged, but I haven't in 5 years. I haven't had a screw break.
Okay. It's a matter of just going in there, tightening it up, and.
Yeah, I mean, I think that the screws are made so well now. They're made of titanium. They're just so strong that they're just not breaking.
And they're going to get close to the nerve.
Well, the nerves.
So how do you know if they're getting close to the nerve?
Right. That was a problem that's been around, and maybe if we have time a little bit later, I'll tell you about one of my favorite things. Is something I patented.
Why don't you go into that? We have about 15, 20 seconds, so give me a quick one on that one.
Okay, good.
Go ahead. 20 seconds.
Okay, so I actually have a patent on a procedure that it's made by Medtronic, and it's now being used in about 250 hospitals in America and all over the world, including China and Japan and even Saudi Arabia.
And what does it do?
And what it is it's a way of putting in the screws in a safe manner, and we use this. This is the device that I patented, and what it does is it's electrical, and it allows us to make a hole safely in the bone without injuring the nerve.
That's great.
And so it's really exciting. That's sort of one of my
That's terrific, and good luck with that, Dr.
Thanks
Neubart.
a lot.
Hey, I want to thank you so much. We're out of time. We just starting to get started and having a great time.
And good luck with your show. I think it's going to be great. So we're glad to have you.
I appreciate it. Thanks for coming by, Dr.
Okay,
Neubart.
thanks a lot.
Okay.